Hi, everyone. We will give it a moment or two before we officially start, but we are happy to see folks coming in to the virtual room today. As you're getting settled, feel free to use the chat box, select everyone, and give a quick introduction. Tiff on our team has kicked that off. We would love to hear from you all. This topic can be very personal for folks, and often we hear stories when we do learning activities around dementia and caregiving. Many folks have really powerful insights to share, so we'd love for you to keep the conversation going in the chat, and we'll talk a little bit as we go forward on ways to ask questions from our fantastic panelists today. So as folks are joining us, thanks to those who are kicking off the introductions, I wanted to give an official hello and welcome to this webinar focusing on recognizing dementia early with the help of family or informal caregivers. You can go to the next slide. Just a few reminders. We all are pretty familiar with Zoom at this point, but this is a webinar versus a meeting on Zoom. So all participants are muted to prevent background noise. But as I mentioned, we'd love for the conversation to stay active in the chat. Please do utilize the Q&A feature while our presenters are speaking, and we'll have a good amount of time towards the end of the hour to chat with them, to pass along your questions. So we'd love to hear from you. We will make sure that all registrants have access to the webinar recording as well as the slides after the webinar wraps up, so likely before the weekend. So rest assured you'll get the information. And then as always, we will have a quick evaluation at the end of this session that will pop up for you. We really value your feedback. All right, so this webinar is brought to you by the National Center for Equitable Care for Elders. My name is Ariel Mather, and I am the Senior Program Manager of our center. If you are not familiar with NCECE already, we are a training and technical assistance provider for health centers across the country, focusing on a variety of patient care topics for older adults. There's a lot of ways to stay connected with us. So if you are not familiar yet with our center, we encourage you to check out any of the links to our social media pages as well as our website, which Tiff has linked in the chat. Another one of our upcoming learning opportunities is happening in just a few weeks, and I think is very relevant to this conversation as well as we think about the growing aging population being served by health centers and how we can better prepare the health center workforce to meet those needs. So we're hosting a 4-session learning collaborative series starting in early March, focused on improving community-based geriatric care. This opportunity is open to patient-facing positions of all kinds, all levels at health centers, as well as leadership who are interested in exploring ways of making healthcare more age-friendly. So there is a link where you can learn more and apply. Tiffany also put that in the chat. We'll make sure that that's accessible to you when you receive the slides as well. All right, so when you signed up for this session, you saw these learning objectives, but we are wanting folks to walk away from this webinar today really believing in the central role that family caregivers play in the health and well-being of older patients. This has been a passion topic for our center for quite a while, something we try to emphasize frequently, just the true value of family caregivers as part of the interprofessional care team. We also want to dive in a little bit more to differentiating between dementia, other age-related changes, undetected cognitive impairment, kind of the reasons why it might be difficult to initially diagnose, how we can work with caregivers to effectively communicate signs and symptoms to look for, and really just have a stronger relationship all around to make sure that our older patients are getting the care that they need when they need it. Yes, thank you for introducing yourself, everyone. I love to see that in the chat. We have 2 fantastic panelists today, and I say that every time we have a session, but we have two individuals who really bring with them a wealth of professional and personal knowledge on this topic, and I feel very fortunate to be able to learn from them. I'll briefly mention who they are and then allow them to present. They will go back to back. You'll be able to read further information on their biographies by clicking in to this slide when you receive it. And I believe Tiff will also put links to their individual websites if you'd like to learn more as well. Our first panelist will be Dr. Lynn Hollerman, who is the former director of palliative care at Stony Brook University Hospital. She is also a health science journalist and one of our fantastic subject matter experts at NCECE. We are also joined by the wonderful Katie Brandt, who is the Director of Caregiver Support Services and Public Relations at the Massachusetts General Hospital Frontotemporal Disorders Unit. And she also is a fantastic speaker and advocate. And again, I can't be more excited for this conversation today. Please make sure you're giving your feedback and your questions in the chat and the Q&A. Without any further ado, I will pass it over to Dr. Hollerman.
Hello, everybody, and welcome. And I'm so happy that people were able to get onto a webinar in the middle of their workday. So I'm very excited. You can go to the next slide. Okay, so I wanted to start with sort of the bigger picture just for a second. If you go into the press about Alzheimer's, you're going to see a lot of news these days, and I tend to track it. It's not all good news, but what I've been noticing is a tendency to, recognize the importance of recognizing early cognitive problems for in articles geared towards the general public. And, that surprises me a little bit because it's definitely a trend in that direction. But, the bigger question for us is, okay, if you've recognized it, then what, now what? So from a perspective of a caregiver and a provider, what's next in that conversation? Now, just a little bit about myself. I'm not going to go into much detail about my background other than to say that I have about 30 years of working with patients with serious chronic illness and their families. And I can tell you very wholeheartedly that it's an area that I've just really loved working with families and trying to problem solve with them. Incredibly satisfying work. And I have a feeling a lot of the people on this webinar are in that care space now. So I'm really hoping that you can leave the talk with some ideas really just to take away for your own practice. Okay, next slide. Okay, so this is just a report from the Alzheimer's Association. It's their 2024 report that came out not that long ago. I encourage you to check it out online. It's very readable. It's packed with information. If it helps you to kind of deep dive into some of the details about Alzheimer's. The thing I want you to notice about this infograph that they have here is that about 5 of the squares on this infograph are really related to caregiving, either stats about them, impacts on caregivers. And that is because when you talk about dementia care of any kind, it's really deeply, intertwined with family care, family support, and how families can help you take care of your patients. So I just want to keep that in mind. I would say to you, the number one intervention that you can do way at the beginning of someone with mild cognitive impairment is just understanding a patient's support system, what that looks like, and how robust it is. And that's important from the various early stages of illness. Okay, you can go to the next slide. Okay, so the focus for me, I'm going to take about a total of about 20 minutes before I hand it over to Katie. And we're just going to kind of look at what are these little high impact, easy to accomplish interventions for patients with mild cognitive impairment that you can implement as part of your care. Next slide. Okay, so we're going to use a case study to sort of examine some of these questions. Here we go. So you receive a call from the daughter of an 82-year-old patient, Mrs. H. The daughter is concerned that her mom is asking the same questions repeatedly in the same conversations, doesn't remember what she's being told after doctor visits. The daughter, who is a doctor, is requesting her mother be referred to a memory specialist for special testing and evaluation. You've known the patient for about 10 years, has a bread and butter kinds of problems in her health, hypertension, GERD, osteoarthritis. Last visit about 6 months ago. You don't remember her having any memory problems, and you know her to live independently, and she's widowed. So the spoiler alert here actually is this is actually my mom. And I put this picture up here for a very specific reason. For one thing, if you just kind of take it in, this is someone like very lively individual. She would kind of refer to herself as a party girl. The gentleman standing next to her is her boyfriend that she acquired, in her late 70s after a 54-year marriage. We were thrilled. This is someone who really is at the top of her game, I'll say, in her early 80s. And the reason I picked this particular picture is simply because it's when our family started noticing some memory problems. And it took us probably about a year of sort of trying to figure out what was going on with her before we sort of say, there's a problem. So the question is here, what's next? What are you going to do next? What's your next move? Now we're going to come back to this. I just want to give some bigger picture views about Alzheimer's. Just to remember that dementia really is an umbrella term, and Alzheimer's is a type of dementia. And it's usually when we talk about dementia, it's usually affecting memory, thinking, mood, affect, daily activities. And a lot of us speak about Alzheimer's simply because it's the most common one, where a very large number of older adults that end up with cognitive impairment have the Alzheimer's type. So I just wanted to point that out to you. Families get confused about these terms, dementia, Alzheimer's, a lot. So you just want to be clear in your own head about that. You can go to the next slide. Okay, so these are some of the common types of dementias. And I think in my mom's case, she probably had a mixed dementia, that she had probably an Alzheimer's with a combination of cerebral vascular disease in her case. And the thing is, you want to just read through these different types of dementias and just sort of get familiar with it, because what you don't want to do is, if your patient is coming in with some atypical signs, you're just not sure what's going on with them, particularly if you know them well and their behaviors are not really matching who you knew before, they're acting in weird ways, to kind of just ask yourself, could something else be going on here? And if you're not sure, just get some help, ask your colleagues to, see them, or make a referral if you need to. So this is just the spectrum of dementias that you may or may not come across, understanding that Alzheimer's type is probably the one you're going to see the most of. Okay, next slide. So you're going to see this word mild cognitive impairment flying around. That's what we were seeing in the press. They're using that word MCI. And for the most part, it's going to come across as these sort of memory slips for people. And it can present in other ways, but that's the most common one. And in the case, I can tell you with my mother, if you met her for like 5 minutes or more, you would never realize she had anything wrong. She has a high social intelligence, very smart lady. And unless you know her well, or you talk with her for a while, you might not understand that she's not retaining some of the things that you're telling you, and she's starting to ask some questions over and over. And then there's some people who can live very well with mild cognitive impairment, and it's not really impacting their function. But truth be told, you're never really going to know for sure unless you have other reporters for a patient, meaning the people in the lives that surround them, to sort of help report out what's happening to them. It can be sometimes very difficult to just use the patient themselves to figure out if they have some memory slips. The next slide. With my mom also, I remember at first, I just remember being a little bit frustrated with her and angry a little bit, just that she wasn't listening to me because she wasn't taking in information about the kids. And it took a while, like, to connect the dots. I had to speak to my sisters and ask them, is mom repeating herself in the same, conversation over and over? But if families are bringing this to you, you can be the one to help them connect the dots. And I just want to emphasize that over and over. You may need the one. I had my sisters to do it with me, but you may need to be the one to help a family member connect the dots. Now, I want to just focus in on these issues of families can get very, very confused with early signs, and I've heard this over and over and over. I have thousands of hours of working with families, trying to help them sort out what's happening. And one thing I always heard is they would say, "Oh, she's just aging," or "He's just aging. It's normal aging." So as a provider, you really want to be sort of clear to make those distinctions. For instance, the first one, trouble holding on to new information. If you look at sort of patients with Alzheimer's, for instance, what they have a lot of trouble doing is that they have trouble laying down new memories. So, or holding on to new information, meaning that they can often recall backwards into their past, their long-term memory. So my mother, she could talk about her wedding day. She could talk about a lot of things. Her child told her, she could go on and on very accurately about those things, but she might not remember like what she had for breakfast, or she might not remember that she didn't take a medication or what medication she's on. So it's this short term, and it's this laying down of new memories that can make it it can be start to get dangerous for people when they can't, when their short term memories start to fail. Um, and you can see this in other ways. You can see it with working with numbers. The one we had trouble with my mother is this trouble interpreting spatial relationships. She started having falls. That's where you get the car accidents start coming in with patients, because they start their depth perception starts to be off, and their reaction time starts to wane a little bit, and that's very typical for people with a little bit of MCI. Um, the other thing you can see, you lose something, but then you don't remember that you lost it. Or in my mother's case, or what happens, like she, hid her jewelry somewhere, and she didn't even remember that she hid the jewelry, and then she thought someone stole it. So you start to see things like that where people actually can't remember that they lost something even. And those are kinds of signs that it's not just aging. Most of us, when we lose something, we're like, oh, darn, I lost that. And in my case, I lose my keys all the time. I actually have one of those Apple things on it to find them, but I actually usually remember that I lost them. So even though I can't exactly remember where they are. So you have to be able to make those distinctions early and sort of work with your families around that. All right, next slide. Okay, so I just want to talk about your daily practice and where dementia care, where you want it to fall. And this is something I did a lot because I was a program director for palliative care. And I would often be looking at our interventions for particular types of patient cohorts, like patients with dementia, and try to figure out in my day, or in the interdisciplinary team that we had, how can we keep everybody in the high impact, easier to accomplish arena for their patient care? Because days are just, you're busy, your time is short, and you want to find those things that you could really intervene quickly, and really have a high impact on your patient. For patients with dementia, the first place to start always is to look for, if we're talking about mild cognitive impairment, to look for reversible causes of dementia. You just want to do that. And I'm going to go back to that in a little bit, but this is just bread and butter primary care. But if someone comes in with a little cognitive impairment, just don't assume automatically that they have dementia as the reason for that. You really want to do a very thorough bread and butter primary care workup around making sure there isn't something reversible. And it's incredibly satisfying to do that. I love being able to fix stuff and watching, the MCI kind of go away or get better a little bit. The other thing I just want to point out is it's impossible really to care for someone with my MCE without doing a really good, thorough functional history. And you may need a secondary reporter for that. For instance, my mother, she had, mild cognitive impairment by her neuropsych tests. However, she, it didn't feel that way as a family member that it was mild. Like, for instance, if I opened up her closet in those early days and I would see 4 or 5 outfits with the tags still on them that she had bought, and there's a credit card bill of $500, and she didn't remember that she even had these outfits. So these things would start to sort of crop up that can be actually quite hard to manage. And if you have contact with a family and you don't kind of explore what things are happening on the front lines of their care, and you're just relying on like a neuropsych test, you're not necessarily going to be helping them that much if you don't do these what we call detailed functional histories. I call it kind of physical functional history. I call it the head, shoulders, ears, and toes, physical exam. That's literally where you're starting on the head and working your way down. And for patients with mild cognitive impairment, you want to just figure out, do they have visual impairment? My mother, for instance, had like a ginormous cataract that we decided to take out when she was in her high 80s because it was messing with her proprioception and her depth perception. And she was falling. And we thought this would be a good way to minimize the impacts of her cognitive impairment by dealing with the cataract. The one that my personal fan favorite is, actually cleaning somebody's ears out. I mean, it sounds so basic to get the wax out because you could just sort of watch MCI kind of melt away in front of your eyes because they actually couldn't hear you. With our palliative care team, I'll tell you that we have these things called pocket talkers. They were not very expensive. We had a bunch of them. We bought a bunch of them for our group. And basically patients could put earbuds in their ears and then you talk into this, gadget that amplified the sound and they could hear you. And it was like miraculous because you could actually, people with a little hearing impairment who are presenting as having cognitive impairment, all of a sudden could hear you. I also used to love to use a stethoscope. We used to have the throwaway in the hospital and I would put the stethoscope in someone's ears and then, like, hello, Mr. Johnson, and I get this, oh, I can hear you, it's like kind of a miracle. So I really want to encourage you, just do basic things, clean your ears out, look at their mouths, dental care. A lot of times people are starting to forget how to brush their teeth. They're not brushing properly. And you can start to see problems along there. So you just want to kind of go down that way, go down their bodies and kind of look for what I call these functional physical things that can impact whether how bad their MCI is or whether you even have it at all, actually. The other things is just you want to avoid things that are low impact, things that are redundant with these patients. And I just wanted to alert you to try to spend most of your day to working at the top of your license in these high impact, easier areas for your patients with cognitive impairment. Okay, next slide. Okay. So here are some of the things to think about. These are with patients with MCI, just to make sure you're not missing something. Alcohol use, you got to ask, it doesn't matter how old they are. And even small amounts can impact older adults with cognitive impairment. The rules that apply, the minimum 2 drinks for women, 3 drinks for men a day, it doesn't necessarily apply to these patients. And some of these patients, you just might find that they've really exacerbated some MCI by the amount that they drink. As everybody knows, there's, a cannabis issue, gummies and things that are, I gave my father a gummy, for his arthritis pain, but those actually can really impact people's cognitive abilities. So you got to ask. Tons of medications, and then just do basic workups, thyroid, vitamin deficiencies. Also, don't forget to check, for possible syphilis if they're sexually active, because I wouldn't make assumptions about that, especially in the days of Viagra. So don't forget that, to do those kinds of really basic things to find out. Okay, next slide. So here are some of the common misunderstandings that families will have. They just think it's normal aging, as I mentioned. And then also another issue is just sort of not being able to see the bigger picture. And the way that that can happen is really that they're so close to the person that they're getting worse, but they're stepping in and supporting that patient, and they're not quite realizing that they're adding in a lot of support for that patient. And I've often seen patients, the patients group that I would see is when that support for some reason disappears, like when the caregiver or something gets sick themselves or they die or something like that. And then you'll see these fast deteriorations of patients with cognitive impairment. A good way to help families with that, I found, is just to sort of make sure you're hearing the story, their life story. Like I'll have people show me pictures of 5 years ago, pictures of 3 years ago, pictures of one, and sort of say, oh, I see, when was the last time he was totally independent, and sort of get those stories so they can kind of step back with you and see what's happening to someone bigger picture. A lot of families do not understand MCI as the start, often as a progressive illness. As I said, you want to try to reverse what you can reverse because it's greatly satisfying to do it. But in general, MCI is going to progress, and families don't quite understand that. So early, you want to sort of educate your families and patients about this because it's a really good time to hit on things like advanced care planning and things like that, meaning something like, who do you trust to help you with medical decisions if you need them? Who do you have on standby? And I will often use that term, who do you have on standby? Because you want to be as respectful as you can with patients, and you don't want to make them defensive, saying, I'm going to be talking to your daughter now, whatever, something like that. So being respectful, who do you have on standby? Who helps you if you need it? Kinds of things like that. And then just mistaking MCI for someone who you perceive to be difficult, or the family perceives to be difficult, and they're not realizing it's actually some cognitive impairment. Okay, next slide. Okay, we're going to go back to my mom. And just remind her the daughter wants neuropsych testing, and she's got some basic problems. She's in her low 80s and she's showing some signs of memory slips. So what's your next move? And we're going to go to the next slide. Okay. So here's some possibilities. You could suggest to the daughter, she talks to mom about attending the next doctor's visit. That's a perfectly reasonable thing to tell the daughter to do. And if you can get a family member in with the consent, to do it together to start with, that's what you want to do when someone has early MCIs, to try to bring families members in to make it like a group thing to do together in a respectful way. It's never gonna go wrong if you do it that way. Having a detailed conversation with over the phone with the daughter about her concerns, that's an absolutely legitimate thing to do. It is not a HIPAA violation to collect information from the daughter, to find out her concern. It is absolutely not. You're using what we call reporting out in the journalism world. Because if you don't get the whole, the chances you're going to get the whole picture of a patient with MCI, if you just talk to your patients, is a little bit on the low side, because they're probably going to tell you they're just fine. That would be a very common answer. Someone with MCI, they'll just say, I'm just fine, there's no problem. So it's missing a huge opportunity when you don't bring in a family member. And if they're coming to you with a concern, to just call them up, find out, and get a detailed history from them about what's happening. Put in a request referral and then follow up with the daughter when it's done. Well, truth be told, that's actually what happened in our case, because the person just, she knew I was a doctor and she didn't want to deal with me. So she put the referral in. But in general, you really want to try to get your patient and your daughter in first, do your evaluation, do this bread and butter primary care workup, and then see, about the neuropsych testing. And then you can speak to a patient about their memory issues. You just want to be just very respectful when you do that. I don't ever remember saying to a patient, oh, hey, I think you have dementia. It's a really unhelpful thing to say. They're not going to remember. And usually it might be something along the lines, I see that you've been having problems remembering to renew your prescriptions. How about we'll work together to see if we can solve that problem. So if you make it very, very task action based with your patients, and not, you just sort of say, oh, you have this, you have dementia, because there's just too much stigma. The chances that you're going to put your patient on a defense is high. So I just sort of want to sort of say, use an action-based approach with these patients. Next slide. And then you want to just look for patterns, and it's hard to do that if you don't have a secondary reporter for a patient with dementia, meaning you're starting to see deteriorating dental care would be very common. Car accidents, my mother was getting in a lot of fender benders. We finally had to get the keys to disappear, basically. And you can get medication mix-ups, you can have no-shows. So if you know your patient, if you're working with someone and you're starting to see patterns, that's when you want to say, is this patient have some cognitive impairment? Next slide. And I'm going to leave it with this sort of like, just remember to listen. And I know Katie is going to talk pretty extensively about this idea, but truth be told, when you think about dementia care, think of it as sort of a family And I use the word family in the biggest sense of the word, kind of enterprise, and it can be an incredibly satisfying thing to do as a provider. I think I have one more slide. Yeah, and just so you know, remember to fix what's fixable. It's like incredibly satisfying and can make a huge impact early with your patients. Use your interdisciplinary team, because I don't think dementia care is something that needs to go across all disciplines and to work together. And to remember to recognize caregivers as inherent to good care of your patients with mild cognitive impairment. Okay, so I am going to leave it there. I'm really thrilled to introduce Katie Brandt. I'm really looking forward to her words about this. She is truly a national expert and leader in the field of family advocacy and caregiving. And I'm just going to hand it right over to you, Katie.
Lynn, wonderful. Thank you so much. And you know, what I love about the two of us is we each have a case study about someone we love, and I think it will represent different sides of dementia care. So, yep, you go next slide and next slide. So, my role, my professional role, I'm the Director of Caregiver Support Services and Public Relations at Mass General Hospital's Frontal Temporal Disorders Unit. We are a clinical research program focused on caring for individuals living with young onset and atypical forms of dementia. And in that role, I'm privileged to work one-on-one with families at every stage of diagnosis, like from diagnosis all the way until passing. I'm able to speak out as an advocate, to run educational programming, and also to coordinate fundraisers. Here we are, this nice group photo. There's Dr. Brad Dickerson, our incredible director in the tuxedo right in front. And this is a great opportunity. There's so much power in philanthropy because when we think about Alzheimer's and frontal temporal dementia and related dementias, there's not a cure today. So how are the ways that we can empower families? And I always say, it wasn't a job description that brought me to this role, but was a love story. Next slide. And so here's a picture of my husband, Mike, and I. We were 22 on our wedding day. Here we are on the steps of St. Anselm College where we met. And on our wedding day, um, I was the only one of the two of us who had a job working at early intervention. I think I was making about $24,000 a year. We had a used Buick gifted from my parents and some furniture from my meme's house that she no longer needed. And we were so excited to set off together to start our lives. Next slide. And 5 years went by. We both earned master's degrees, Mike in theology, mine in nonprofit management. We had jobs that turned into careers. Right before our fifth wedding anniversary, we found out that a baby was on the way. And I really just love this slide because it's just an opportunity for me to share this shameless, gorgeous baby photo of our son, Noah. We bought a 3-bedroom house. And it just seemed like, oh, well, this is everything that we wanted, you know, family, meaningful work in a community that we loved. Next slide. And my wonderful, caring, sweet, smart husband started to exhibit some changes in his behavior and personality. He was impulsive, spending money on things we couldn't afford, eventually racking up $28,000 on a credit card. I started getting phone calls from friends saying, hey, is Mike mad at me? He never wants to hang out. And my husband was incredibly outgoing and had a wide circle of friends. Apathy. Mike ran a small web design business on the side to supplement our incomes. And he had a lot of clients who were getting very upset with him about the quality of his work, his inability to meet deadlines, and he didn't seem that bothered by it. When previously he had an incredibly high work ethic. He had compulsive behaviors. One in particular, he was obsessed with listening to the Harry Potter audiobooks. Um, I love Harry Potter. Mike and I loved Harry Potter. You know, we would happily read all of the books, but we'd read them all before. We'd listen to the audiobooks, and he would listen to them while driving in the car, cooking in the kitchen, before bed at night. In fact, when I was in active labor with our son Noah, I had to say to him, take those earbuds out of your ears. So really unusual behavior. Changes in communication. We used to always talk so much, and he just really seemed more withdrawn and noticed that he was having trouble writing, like even writing a grocery list. We were trying to make a list for Mexican food, and he couldn't spell the word rice or avocado. Struggles at work. As a teacher at a high school, a private high school, he needed to wear a tie as part of his dress code. And first he got a verbal warning and then a written warning, and then he was at risk of being suspended at a time when we had a new baby at home. And when I said, "Why aren't you wearing your tie at work?" he said, "Well, I just don't want to." So all of these difficulties leading to changes in daily functioning, relationships, and communication made me wonder what is going on. Next slide. So I started going with Mike to the doctor. I went with him to his annual physical appointment, and I said to his primary care physician, "My husband is acting so weird. Could he have a brain tumor?" And she was the first of 8 medical and mental health professionals to misdiagnose him. And we'll talk more about that. Next slide. Finally, I was able to bring Mike to Beth Israel Deaconess Medical Center in Boston, where he saw, at the time, the chief of cognitive neurology, who diagnosed him accurately at the age of 29 with behavioral variant frontal temporal dementia, which I will refer to as FTD. So, what is FTD? I bet that some of you in this Zoom room have had patients or families impacted by FTD. Maybe for some of you, you're hearing about it for the first time, or you've heard of it, but you've never met anyone living with it. You know, it is considered a related dementia to Alzheimer's disease. It has a typical age of onset a full 20 years earlier, like in someone's 50s, whereas the typical age of onset for typical memory-based dementia and Alzheimer's tends to be in the early 70s. FTD is the most prevalent young onset dementia, and young onset dementia is categorized as dementia onset before the age of 65. And it's anticipated that around 60,000 Americans are currently living with FTD. You might have heard about it in the news because Bruce Willis is living with FTD, but it's not well diagnosed. So those numbers are likely very low. And just, I always say to families when I'm talking about, what's the difference between FTD and Alzheimer's? If you had this like really short lay description, it's thinking about how Alzheimer's disease typically starts in the back of the brain and has that early presenting symptom of memory. That's what people associate with old age, with Alzheimer's, with dementia, memory. But when we think of FTD starting in the frontal lobes, like Mike's did, you have those early changes in personality and behavior. And when the temporal lobes are affected, you see those early changes in communication, writing, speaking, reading. So this can be a very atypical presentation, and it can be difficult for clinicians and healthcare providers to catch it and diagnose it quickly and accurately. Next slide. What is so important to remember is that the day that you hand out a diagnosis of Alzheimer's, FTD, or a related condition, you're actually handing out a double diagnosis because that day someone has likely been diagnosed as a caregiver. They might not even really know it. But we know that being a caregiver is a threat to your emotional, physical, and financial well-being. Medicare data tells us that caregivers of loved ones living with dementia, family caregivers, are likely to have higher health care costs than non-dementia caregivers. We need to ask ourselves, how is it that we have a disease that is not contagious, but in fact, it makes other people sick? Other people in the orbit of the person with the diagnosis can also become sick, have higher chronic health conditions, higher risk of cardiovascular disease, higher risk of dementia and mortality. And then we need to ask ourselves, how in fact are these risks different or even amplified when a caregiver is from a vulnerable population? Vulnerable meaning living in low socioeconomic status, being a person of color, a historically marginalized population, being a young onset family. How are they different? Next slide. And so it's no surprise that the caregiver mind is often overwhelmed and in all directions. So this slide is meant to be overwhelming. And, one day I made it up. I kind of thought to myself, well, what were all the things I was thinking about, to be a caregiver, a provider? That no one person could hold this all in their mind at once. And so, next slide. When we think of caregivers as critical team members, we need to know that you're working with a partner that has critical information, not only about the values and the goals of care that your patient holds dear, but also they are the first to notice changes. They are going to be the ones who can likely provide you with an accurate patient history. They're going to be the ones coordinating the appointments, helping with medication, making sure that your patient is doing all their activities of daily living and keeping them safe related to finances, safe related to housing, safe related to relationships. They'll be the advocate for the patient's values and goals of care, and they are going to be critically important to make decisions during advanced care planning. So, partnering with family caregivers has this amazing potential not only to enhance quality of care, but to enhance quality of life for the person living with the diagnosis and the care partner. It has the ability to help you as a provider protect personhood and dignity for your patient at every stage of life lived alongside dementia. Next slide. We do not yet have a cure for dementia, but we do have a cure for the isolation and loneliness that may come with a diagnosis. Next slide. I want it to be a requirement that every healthcare provider, every healthcare member needs to be able to write a prescription for connection. So meaning if you have a patient living with Alzheimer's disease, you must refer them and their family to the Alzheimer's Association. If they're living with FTD, I want you to refer them to the Association for Frontotemporal Degeneration, the Lewy Body Dementia Association. And why is that? Because this is a place where families can connect with others in a similar situation. They can receive emotional support and care. They can receive information from a trusted source. None of us want our patients or families participating in the midnight Google, right? We don't want them going online, putting in symptoms, and becoming scared. They can also learn critical communication and behavior management strategies because oftentimes one person living with dementia, their symptoms may present differently than another, but the tools that the caregivers can learn, and we can go to the next slide, can be applied across many different types of dementia. So I'm just going to give you a couple of phrases that I always hold in my mind when I'm working with caregivers for like communication tips. Feel free. I know you're all going to get these slides. But I love thinking about the work of Dr. Paul Rea and the habilitation therapy model of care promoted by the Alzheimer's Association. And one of the first things is spending 5 to save 20. So coaching, whether it's families or professional caregivers, when you're going in to do personal care, when you're going in to tell your loved one, hey, it's time to get in the car to go to the doctor's appointment, spend a few minutes on that relationship, hold hands if it's appropriate, ask them how they're feeling, maybe talk about the snow falling outside or the beautiful sunshine that's going to greet you when you walk out the door. And that can help to build that relationship and that trust and that connection for whatever is coming next. Feelings first. This really connects, I think, with this idea of more than words. Look at this picture. Look at my face. I'm trying to connect with Mike. This photo was taken in his room at his skilled nursing facility, and we were there for a family visit. And what am I trying to promote? Connection, joy, happiness. I'm going to start with a smile. I'm going to start with my eyes. I'm going to start with my body language. I also cheated. I started with a treat. He's holding his Dunkin' Donuts coffee, which he loved. But reminding families, like, if you walk into the room, all right, Dad, come on, we got to go. Get in the car. We're late. They might not really understand the words that you're saying, but they're going to see, like, you're really upset about something. That's going to make people put on the brakes. But if you walk in like, hey, I'm so glad to see you. We're going to do something together today. But first, we got to put our shoes on. Let's get going. It really can impact how the person living with a diagnosis feels. And feelings are really a big part about making connections and getting through the day, even finding joy. So, and no more no, just really trying hard not to say no when your loved one wants to do something, but instead to like divert and distract. Next slide. So I like to talk to families about control and letting go. So what is it that we can control? We always have to think about safety first. So we can control things like the environment. So for example, my families who have firearms in the home say you can control the fact whether or not you have firearms in your home. So asking them to lock them up, remove them, give them to a family member. You can control your approach, just like I talked about, coming in really busy, coming in, as I say, coming in hot, right? Come in calm, come in cool. And you can control your response. So when your loved one or your patient meets you with a lot of anxiety or even aggression, saying, instead of trying to like push back against that or yelling, calm down, maybe he's just saying, wow, I can see how upset you are right now. That must be really hard. Offering a hug, offering words of encouragement, just that you can control that, but you really can't control the person living with the diagnosis. You really can't control Alzheimer's or FTD. So just thinking about what can you bring and let go. I say if it doesn't hurt anyone, let it go. We had a patient that was obsessed with dusting and it annoyed his care partner, but we talked about how the dusting gave him purpose. And really, he wasn't hurting the furniture, he wasn't hurting anyone. So she learned to let it go. Let go of expectations, like especially around the holidays or birthday parties, special events, maybe even like, hey, I expect that every Friday we go out to dinner at this restaurant. Well, maybe you used to go at 6 p.m., but now you're going to go at 4:30 because the restaurant's a lot quieter. And your expectation is just that you're going to get through the meal without anyone being upset. And really let go of other people's opinions because they don't know what it's like to be you. Next slide. So my key takeaways are I want to help families, I want to help providers make connections, right? I want providers to connect with family caregivers so that they can really understand what is it that their caregivers want, their patients want the most. I want families to connect with community resources like their area agency on aging, like their local senior center, their local YMCA, the Alzheimer's Association. I want families to focus on communication, which is so much more than words, right? To control what you can, let go of what you can't, and to know that you still have the opportunity to make new memories of joy. Just because dementia has come into your life does not mean that love and joy have to go out. So thank you all. For the last slide, it's just really, I have such a gratitude for those who choose to work in this field, who choose to work in the field of geriatrics, who support family caregivers. It is still such a difficult journey. And so thank you all for bringing your professional energies to this community.
Thank you so much to both our wonderful panelists. Love to see the little hearts floating in. I know this is a topic that intersects with a lot of folks' personal lives and professional experiences, and just want to honor that. I agree with the chat. Your compassion and love shows through your materials, Katie. Thank you. We have about 10 minutes to play with. We do have a question in the Q&A and would love for folks to think about any additional questions they might want to pass on to our panelists. I will pass this one first to Lynn and see what her thoughts are. So this individual indicated a personal experience around going through what Katie had talked about a double diagnosis, and wondering about the idea of worrying over if there's a family history, worrying that they're next for that. Is there a way to tell if they're at increased risk from that worry itself? So just curious the amount of stress that might put on someone. Lynn, what are your thoughts on that?
I mean, just from based on my personal experience, you definitely start thinking about that. Mom had dementia. Am I going to get it? You can't help it. I, for me personally, it's just sort of doing as much self-care around brain health as I personally can for myself. And if you can sort of gently make those suggestions to your family members, and whether you can say, whether there's a genetic connection or not, that can be tricky to do for someone, especially with Alzheimer's. And Katie, do you want to make any comments about that part also?
Yeah, I mean, of course, there are some genetic causes that increase your risk, right? But in fact, I remember this one particular family I worked with where they did have a genetic indicator, and the son developed FTD in his 30s, but the father was 75 and he had not shown any clinical symptoms. So genetic risk is only one of your risk factors. So I love what you said about focus on brain health. And that's when we tell our caregivers, self-care, care for the caregiver, that is required. It's not a luxury. It's about your health, and your health being strong can help to make your loved one's life and their health better. Yeah.
Absolutely. We have folks expressing appreciation and sharing in the chat. I agree with Karen that there's so many great life lessons in reflecting on those communication considerations. I'm in a lot of challenging situations we might find ourselves in. And someone was mentioning just maybe the correlation or exploring potential connections between other conditions and risk of dementia. And so there's a lot for both clinicians, staff, family caregivers, the patients themselves to hold in thinking about both risk and also navigating through some of those potential initial signs of mild cognitive impairment.
So I can comment on the retinal detachment. So I haven't actually seen that particular study to make any specific comments, but it comes back to the point of that when you have someone presenting with mild cognitive impairment, to just do that whole body functional assessment. I call it the functional physical: head, ears, shoulders, knees, and toes. And where you're really just sort of seeing the things that can impact people's cognitive impairment and really in some case reverses it. I mean, I could get giddy over doing stuff like that as a clinician, where someone comes in and they have something going on. Particularly hearing and seeing can be big ones, that when you fix those things to a certain degree, you can actually reduce their MCI. So that's really what I would say with that. Just go to basics, go to primary care basics, and fix what you can for that patient. It could be really huge in terms of their ability to function.
Mm. We have, and I know, Katie, you mentioned some of the community resources that could be available, and we have someone sharing an experience of a friend in the chat. And as a quick summary, saying that a friend whose wife just had been diagnosed with early onset dementia, worried about her diagnosis due to seeing her sister struggle, and then the husband is seeking out counseling, which is fantastic, but wanting to know what other resources they could both be looking at, and kind of any other guidance that you might share that this person could pass along.
Yeah. So the first thing I'll say, and we can just put alz.org in the chat, but Does everyone know that there is a 24/7, 365 free helpline available through the Alzheimer's Association for people living with any type of dementia? And it's not just people who are there to pick up the phone, but it's actually trained clinicians. So let's say this has happened to you and you're like, okay, my wife has just been diagnosed with early onset, but I still have to go to work. So I'm just going to ask someone to check in on her, but I don't even know what other resources there are. You could call that number at 1 in the morning when you're sitting up worried about it and say, my wife just got diagnosed. This is the zip code where we live. Could you send me a list of possible resources? And an incredible resource for people living with a diagnosis, experiencing dementia are local adult day health programs. And I know that every community doesn't have adult day health programs, but for those that do, please refer your families to connect with them. And so many families will say, well, my loved one doesn't need that yet. But you know what? All of us need purpose, connection, cognitive stimulation, fun. And being a part of a community is important for everybody. And you'd just be so surprised how your loved ones can flourish when they're in a space with people who are protecting them, providing them with cognitively appropriate activities, nutrition, hydration, and they're more affordable typically than obviously a residential memory care or even hiring someone one-on-one.
Absolutely. We have just a couple of minutes and we've gotten two good questions in the Q&A. So we'll try to at least get brief responses from both of our panelists. A question around the value in dementia care navigation. Certainly, depending on the healthcare setting, there may or may not be care navigators for a variety of topics or patient populations. Any thoughts, Katie or Lynn, around dementia care navigation specifically?
I'll chime in first and then I'll have Katie pick it up. But prevention, it's what home safety, if you want to do really something impactful for your patients with mild cognitive impairment, if they've been diagnosed, if you can get a home safety evaluation, and that includes lighting, carpets. My mother fell off the toilet twice and broke her wrist, dislocated. You can get the special, there's all kinds of things, carpets that's too thick, so they tripping. So I would say an early thing to do is a home safety, if you can figure that out for the patient, if they'll allow it. Sometimes families just don't want people in their homes, and it can be tricky, but if you can pull it off and convince them, I really highly suggest that as a real starting point, is doing home safety evaluation.
And Lynn, I think people can request that from their local area agency on aging, which
Yeah, that's true, right?
yeah, which I saw the elder care locators put in the chat. And just as a reminder, uh, the Older Americans Act was updated to include those of any age living with a diagnosis of dementia. So even if you have someone who's 55 and living with a diagnosis of dementia, you should still refer them to the area agency on aging. You should still refer them to use the elder care locator. Um, I was going to say the same thing, Lynn, just try and getting someone out in the house to get to know the family and try to start offering them support.
Exactly.
Amazing. Well, I cannot thank you both enough for your time and willingness to share your expertise and your stories with this group. We had a lot of love and appreciation expressed in the chat, lots of reaction icons coming in. We will be sure to pass along resources from this session to all registrants. We would love if you take just a moment as you close out this Zoom to give us any feedback. It will help inform future learning opportunities. If you'd like more sessions like this, feel free to fill out that survey to let us know. And we'd love to see you at some future learning opportunities. Tiff put the link to our website there. We would love to stay connected. So again, thank you so much to Katie and Lynn for their time today. Thank you all for taking some time out of your day to learn with us and to share your stories as well. Take care, everyone. We hope to see you again real soon.